Good evening, everybody. Welcome to this session on management of solid organ trauma in the abdomen. This is a little involved, and I thought a discussion as such would be a little difficult. So I'm deviating from my normal and I'm giving you a didactic lecture. But I hope that doesn't take away the learning or take away the retention. And I hope you people have read and come, and then you can initiate a discussion of me asking you questions. You can ask me and Ravi questions, and we can see how we can cope with those questions, as it were. Okay. So basically, I'm dealing with spleen, liver, pancreas, and the kidney. Those are the common solid organs that we think of. Pancreas is practically inseparable from the duodenum. If one is damaged, the other is automatically damaged, almost always. And so there will be something said about duodenal damage as well, even though it is not a solid organ. Before we start on the specific organs, I have to recap what we have discussed in the previous session. Always remember that solid organ injury doesn't come in isolation. There are always other injuries for the rest of the body. So general, primary, secondary surveys are very, very important. And in taking decisions about how and where you treat them, this is important. Now today you're in a tertiary care hospital, so you don't have to perhaps worry too much about institutional infrastructure. But when you go out, pass out, and you are out there in the periphery somewhere, you have to know what you can manage. You really cannot chew more than what you can swallow. I mean, swallow what you can chew. And so you have to be careful about what you choose. And equally important, even the infrastructure is is very good. What is the available expertise? It's not that everybody in the institution has an equal degree of expertise in a certain kind of trauma. And of course, you must involve teams, even in your own primary, liver injury or spleen injury. It's always useful to involve a radiologist, for example, and a physician. And so even for post-op care, all the post-splenectomy phenomena, for example, it's always good to involve a team for the care of these patients. Again, a recap: CECT, you will find, is the workhorse for all trauma cases. Contrast enhanced, IV contrast is enough. Oral contrast not necessarily required, and a Doppler to look at vascularity in various organs, spleen, liver, kidney, etc. Wherever the trauma, always stabilize the neck. It costs you nothing to put a collar and log roll a patient if you want to check the patient. We have discussed these things before, and I'm not going to talk about it, but just a visual on the screen for you to have a recap. I put a question mark next to nasogastric, so don't automatically put it, particularly if there is an oropharyngeal injury, you suspect, some degree of damage either to the skull base or the nasal passage or the pharyngeal area. Do not routinely put a nasogastric tube unless you're sure that that area is safe to negotiate a nasogastric tube through. Pathophysiology is something you must know. We have discussed this before. In the blunt trauma, it is either crushing against your spine or a shearing force. A blast has, as we discussed, 3 components in it, and a deceleration injury. The classic example being an avulsion or a tear of the hepatic veins. So something which is traveling fast suddenly stops. Then the liver gets practically detached from its anchoring in the posterior abdominal wall, and that can cause a laceration of the hepatic vein. Penetrating with a knife and a sharp RP, you must know the line of trajectory. The bullet damage is more than that line. In a sharp knife, you just have to know the trajectory, and the collateral damage is not very much. In bullet, collateral damage is higher, more than a knife, because of the so-called cavitation effect. And in a blast injury, it is several times more, particularly with the shrapnel, the bits that they use in a bomb that goes through and damages several areas. Okay, these are the pathophysiology. I put it up just for you to have a recap. How do we define an unstable patient? I think the ATLS gives us a very simple, direct direction, direct definition. Pulse more than 120, systolic less than 90, and transient response, which means that you give him some IV fluids, a liter of IV fluids, pressure comes up and comes down again promptly in the next 10-15 minutes. In those cases, do not waste time in shifting the patient here, there, getting tests. Shift them to the operation theater. You perhaps may be able to get a fast, but definitely don't leave them unattended in the CT area. That's very, very important. And I've also mentioned this side by side, along with hypovolemia that you correct. You must have an idea, you must have an eye on the acidosis, coagulopathy, and hypothermia, the so-called lethal trauma. Okay, and what we are discussing today is mostly on blunt trauma because that forms perhaps 95% in our cases. Penetrating trauma is very less, but if you look at the world figures, 80 to 85% are still blunt trauma. 15 to 20 may be penetrating trauma. And in penetrating trauma, there's a lot of papers about conservative management, but I'm very skeptical about it. I think it has to be in very specialized centers, and in our kind of setup, it's good to have a low threshold to explore all penetrating trauma. The exception is a small stab injury where you don't even know whether the peritoneum is breached or not, but we have discussed that before. That's a small exception. But if there's something where there is significant injury, better to always explore or do at least a laparoscopy. Okay. And always, any important higher degrees of solid organ damage essentially means a large force has been in play. And so you have to look at patient as a whole and look at other injuries in the patient. And if you have one organ involved in the abdomen, you must look at everything else in the abdomen, either at laparoscopy or laparotomy. I won't mention much about laparoscopy because its role, honestly, is very limited in trauma and particularly in an unstable patient. And that's the kind of patient you actually operate on. So while it is mentioned for completion, we would take it that we're doing a laparotomy in most of these patients. And it's not just the anatomical damage that you detect or diagnose during your workup of the patient in trauma. You must look at the patient again as a whole. Who are the ones, today is the buzzword is conservative management, NOM, non-operative management of trauma. It's good. I am a great proponent of it, but please be careful that there are certain groups who are more prone to failure of NOM, non-operative management. This is age over 55, initial hypotension, low hematocrit, significant bleed has occurred, patients who are on antiplatelets, who are immunocompromised for more than one reason, not necessarily just HIV. It may be renal failure, it may be diabetes, and other cardiac and respiratory comorbidities. If these are existent in this population, do not hesitate to operate quickly. You may think operation is a big morbidity, but a bigger morbidity is to operate after they have lost a lot of blood or after they have become hypotensive and after their general physiology is compromised 24, 48 hours after admission. So that's a bigger stress on the patient than an initial stress of the operation. So you must bear in mind that you should be less aggressive with NOM in this group of patients. Let's go to organ-wise management. Before we do that, any questions, doubts, comments, please?
You said about diglap in penetrating injuries, sir?
Yes, very much so. So there are two situations which in fact I've actually experienced it. One of them is you have seen, you don't know whether the peritoneum is breached or not. The knife may have gone right up to the peritoneum through the muscles, but not through. And even if it has gone in, your FAST tells you that there is some fluid in the peritoneal cavity. Is it blood? Is it bowel content? You don't know. So do a diagnostic lab. You find that it may be a little bit of blood from one of the peritoneal blood vessels. The bowel may be intact, solid organs may be intact. Knife might not have gone through all this. These are two classes. And of course, if you're in doubt whether it is breached or not, You put a telescope in and then look all around and make sure that the peritoneum is intact. So these are two classical situations where laparoscopy is warranted in a penetrating trauma. Particularly knife, I'm not talking about bullet and blast injuries.
Yes, sir. Yes.
Okay, so let's go organ-wise now. The spleen is the commonest solid organ that is involved. Three special considerations when you talk about spleen. It is overwhelming post-splenectomy sepsis, more common in children than adults. We don't deal with the pediatric population much, but that doesn't mean that you should ignore it in the adult population. Subcapsular hematoma is quite common. 15 to 20% of them may rupture. So while you may go ahead with a conservative treatment, there is some attention to be given to what happens to them after they go home. They may behave very well in the ward, but what happens, and we'll discuss that. And a similar situation is a pseudoaneurysm. So if you have a rupture of the partial rupture or a contained rupture of one of the hilar vessels, you end up with a pseudoaneurysm, and that may rupture as well. That may happen weeks, months, years after a splenic trauma. I've known cases where patient hasn't forgotten that he had a trauma, and then they presents with a spontaneous rupture of a pseudoaneurysm. That's very well described. And so these are the three situations that you must have in mind when you have a splenic trauma. Okay, we are all familiar with this. We have dealt with before. As I keep saying, I don't think you need to mug this up. The picture is there. You can always see it. I'm not going to ask or fail you in an exam if you tell me what is the depth of laceration in a grade 3 injury. I don't think that's what you're looking at. But please understand that what is important is that whether the capsule is breached or not. And if it is breached, you have free peritoneal bleeding. The effect of tamponade is gone. So bleeding will be higher. The deeper the laceration, the worse is the chances of bleeding. So if it keeps going deeper and deeper in the parenchyma, as has been described in grades 1 to 3, you can then have bigger and bigger vessels being ruptured and higher bleeding, culminating in a shattered spleen, which is grade 5. And with or without much of a laceration of the spleen, because of the deceleration injury, the hilum may be affected. So the blood vessels in the hilum may be affected and they may rupture. And as a consequence of that, you can have necrosis of a part, devascularization of a part of the spleen. So when these things happen, they are the higher grades, grade 4 and 4 and 5. And for the lower grades, you have different sizes and depths of laceration and different sizes of hematoma. Okay. The problem, not a problem. The issue is that there is the American Association of Surgery of Trauma, AAST. That's the picture that I showed you. There is also a World Society of Emergency Surgeons. Okay. World Society of Emergency Surgery. So they have slight differences between the two, not a lot. What the WSES has added to AAST is the presence or absence of hypotension, instability. That is the crux of the matter in all abdominal injuries. If the patient has, as I said, is unstable, low BP less than 90, pulse rate of more than 120, you have to factor that in your decision, not just the anatomic damage that you have established through a CT. If you have managed to get one. Remember, if the patient is very unwell, you will not be able to get a CT. So you go only by the AAST classification. WSES doesn't come into the picture. I mean, WSES only. AAST doesn't come into the picture because you don't know the anatomical extent of the damage. Okay, so if it's mild or moderate, then you can manage them conservatively. If it's a severe splenic injury, includes unstable AAST grade 1 to 4 blunt and penetrating lesions. Okay. Please note that in a moderate splenic injury, some people have even said grade 4 can be conservatively managed, even though I personally have my doubts about it. But we are not going to hold you to it. It's a decision that you make on the spot in your ward or in your ICU, whether to explore the patient or not. If he's unstable and if you're not able to deal with it, go in, whatever the grade is. But such situation will occur only beyond grade 3, generally, of the damage. Okay. So not getting into the grades, you have three options: conservative, that is uh, expectant treatment; invasive radiology, talking about embolization, angiogram and embolization; and operative intervention, which is, I have put laparoscopy in very small letters, so I think there's a very limited role, but which generally means a laparotomy. Okay. So conservative treatment, mild to moderate injuries, moderate, observe in the ICU, it's quite okay. But there is a rider to that. Remember that. It's okay in Sagar, but elsewhere, you must make sure that you have facilities for urgent transfusion. So when I conservatively manage somebody in Shanti, for example, I always think, will I get blood quickly? Or I play safe by having 2 to 3 units of blood in the hospital, whether I use it or not. And then you must have the OT on standby all the time. So you must have that in mind. We know about the conservative management, monitoring, and twice daily hematocrit is what we normally recommend. Please note that it is not just hemoglobin. Hematocrit is a more sensitive indicator, and the hematocrit must be determined by actual centrifugation. Some labs just multiply hemoglobin by 3 and give you hematocrit reading. Incorrect. That cannot be done. You must insist and make sure that your lab actually spins the blood in a centrifuge and then gives you the hematocrit. Okay. So if you're doing the conservative management, mild and moderate degrees of injury, bed rest for 48 to 72 hours. You may allow bathroom facilities if the patient is very stable. You may have to repeat the CT. For example, if you have had a grade 3 injury, which you are conservatively managing, you want to know whether there's a continuing bleeding with a worsening hematoma, not amounting to hypotension or great fall in hematocrit, but nevertheless not settling down. So you may want to repeat your CT. And this is the important thing. If you have a subcapsular hematoma, which you have managed conservatively, later on, remember, you must limit the activity for 4 to 6 weeks. Definitely no contact sports for a long time, 6 months to even to a year, sometimes people say. There is no hard and fast rule, but no contact sports. Make sure you don't go and bang against anything. Limited activity. Okay. No sports. Forget about contact, but no sports at all. No partying, no jumping around in a dance and things like that for 4 to 6 weeks. Okay, angiography and embolization. Now, what are the signs of bleeding or active major vessel injury on angiography? One of them is a contrast blush, where the contrast leaves the blood vessel, gives a blush around it. You can have a pseudoaneurysm. You can see the bulge of the aneurysm, or you may have an AV fistula, a quick runoff from the arterial side to the venous side. Okay, and so you can consider angiography and embolization in grade 3 and 4 if the patient is unstable, not very unstable. Again, it's a matter of judgment for the surgeon. You see how he is. You have seen that the patient's grade on CT. You've got a CT, patient is stable, it's grade 3, for example. And then you find that while he's not becoming hypotensive, he's dropping his hemoglobin 1 or 2 grams a day. You've got to give more than 1 or 2 bottles of blood a day to keep his hemoglobin up. In that situation, you can certainly, you know that the patient is continuing to bleed, and you can consider an angiography and embolization. When you do an embolization, coils are preferred to absorbable materials like gel foam. That is the recommendation of the radiologists. Okay. In an operative management, these are the things that we are talking about for the spleen itself. But the line below here is important. Always, when you open a patient, unstable patient for trauma, always have damage control in mind. Okay. And the classic indications, we don't have to, it's obvious. Unstable patients, failed conservative treatment, and associated injuries. If you have bowel damage, for example, as seen by free air or features of peritonitis, increasing distension and guarding, then you will probably have, you will have to operate. Now, when you go in for a damaged spleen, you have 3 or 4 options. Okay, we talk a lot about splenography, but it's actually in the world literature done only in 5% of cases. Okay, commonest is partial splenectomy, and the next in line is total splenectomy. And of course, it's very easy to do, and many of us have done it and will do it. Autotransplantation. In a shattered spleen, instead of throwing away all the spleen that you have taken out, you can just chop them into small pieces and put it between the folds of the omentum. And they can, it's like splenosis, as it were, an artificial splenosis. And they can, some of them will survive. Blood vessels will grow into these little chopped up pieces of spleen from the omentum, and they can function as a spleen. Okay, so that is a very viable option and can be done. Okay, in splenectomy, I'm not going to the operative details of splenectomy. It's like any other case. But what can you do in splenography? Okay, the first thing is, if it's not a torrential bleed, you can just wrap it up with a hemostatic agent, like an ab gel that we have, a gel foam, or like a gelatin sponge that we commonly see. We also have a thing called Surgicel. And you can have several layers of it, wrap up the spleen, over that wrap up with a big mop and hold it for 10 minutes by the clock. Don't keep on taking it out and seeing. If the blood is not oozing out through your fingers, if you think it's dry, just wrap it up completely and hold it, and it'll work. These are very common in capsular tears and shallow lacerations. If it's a little deeper, perhaps a grade 2, okay, less than 3 centimeters, 1 to 3 perhaps, you can suture it. You have blunt, large needles with chromic catgut attached to them, swaged to them. This is a blunt tip, there is nothing there. So you can run it through the spleen, and those sutures will not hold on top. It may tear through. So you can put a pledget, you can put omentum if you want. You can take a bit of free or pedicled omentum, which holds your suture, as well as it's a good hemostatic agent. Or you can put some, again, the foam or a bit of Teflon, for example, something that will hold your thread, and you can suture it. If you see actual spurters, you may sometimes be able to cauterize it. Many times I use a bipolar to see if I can get that organized. Okay, and you can, as I said, have a combination of suture and hemostatic agent. And if that doesn't work, and you see either upper pole or middle pole, or the lower pole is involved, you can just do a partial splenectomy. As I said, partial splenectomy is the commonest kind of operation that's done on a damaged spleen. I've deliberately put a 1990 paper. The fact is that from then to now, there isn't a huge advance, something new, and as far as the splenography is concerned. You can see that in a cohort of 240 patients, which is a pretty large number, a large majority of them were grade 1, 2, or 3. Okay, only 85, about 10-14% were grade 4 or 5. Suturing was one of the commonest things. Partial splenectomy was done, and this was also done. But I don't think I don't think we have a breakup of what was done for each of these. Yeah. So rebleed occurred in a very small number of 1.5% of patients, and splenic abscess in pseudoaneurysm was also very, very uncommon. So all in all, over the last 30 years, we can safely say that splenography is a viable option. And this is splenography. As you can see, they have used Teflon patches to stitch up this bleeding spleen here. And it's a combination of the splenography and partial splenectomy. It's not my case. I borrowed this from the net. But this is the way it looks. I've done such a job. It looks like this when you have done the job. Okay. Post-splenectomy, always remember, patients are prone to infection, particularly the pediatric age group. Best antibiotic to use the penicillin. Thrombocytosis and thrombosis occurs, or thromboprophylaxis until the patient is mobile. And a vaccination, polyvalent pneumococcal, meningococcal vaccine, not to be given immediately after surgery. That's one trap students fall for when we ask. The reason is that they are immunosuppressed at the time of surgery. And so if you give a vaccination, they don't mount a good antibody response. So it is recommended to give the vaccination 2 weeks later after the surgery. Okay. Comments, questions?
Sir, about this subcapsular hematoma, sir.
Yeah.
I've seen few papers saying directly advising for surgery, splenectomy.
Yeah.
Even for a grade 1, grade 2, grade 3 also they are advising splenectomy.
I would not buy that. If you tell me that the subcapsular hematoma is more than 10 centimeters, it's very large, and that you see some parenchymal laceration beneath it, level 3, grade 3 laceration more than 3 centimeters, then I might say, yes, this is a potentially difficult situation. The only justification for operating on anything other than this is an institution where you have no backup with either a good blood bank or you cannot undertake an emergency surgery in the middle of the night easily. Okay. That justifies it because, you may be taking an unnecessary risk when you wait. But otherwise, subcapsular hematoma per se does not warrant exploration.
Okay. Something like obesity and these things are any relative indications, sir?
No, not for subcapsular hematoma, no. But as I said, the failure rate of conservative management is higher. You must have that in mind.
Okay.
Yeah. Okay.
Sir, generally, in a trauma case, is there any particular way in which we start the procedure? Like, is there any timeline that you should enter the abdomen from the incision to the peritoneum? Like, do we have any, because if the patient is hemodynamically unstable, is there any standard guidelines that there should be a quick in and quick out and less anesthesia time, something like that, sir?
There is no need for a guideline. That's common sense, isn't it? So you have a large midline incision,
Yes.
and a similar rule applies to a bleeding abdominal aneurysm, for example. Of course, nowadays, of course, you have endovascular procedures, but I'm sure Ravi will tell me, will agree with me. We were registrars in the UK system. Bleeding aortic aneurysm was very, very common. So we would not even wait for our consultants to come. We would shift the patient, inform the consultant, shift the patient, put an incision from xiphus sternum to the pubis, and try and mobilize the aorta above the aneurysm and put a clamp. By that time, the consultant would come and would probably repair it, and either he would repair it himself or he would let us repair it. Similarly, in a trauma case, have a generous incision, midline, go in quickly and evacuate all the clots quickly. Have 2 or 3 suctions ready because one suction machine will not suck it out. And you don't use that snout or the thing for the suction. Take the whole suction tubing, big clots, put your hand in, scoop the clots out. Whatever other things are there, take everything and then find out where the bleeding is. And then try and stop it, basically by pressure or clamping first, without undertaking any major dissections and anatomical dissections, as it were, without damaging surrounding structures, of course. So, it's common sense that you have a big incision quickly, sooner the better. And literally you can, we have had situations where after the patient is anesthetized, after the patient is draped, we have managed to, get at the bleeder within 10 minutes or even less sometimes.
Okay, sir.
Okay. Anything else? Ravi, you have any comments?
Yeah, I think I agree with all that you said. The quick laparotomy, quick evacuation of hematoma, and sometimes if you're not sure where the bleeding is, take big mops and put mops in all the quadrants, and then from where the likelihood of bleeding is, that where the clot is and things, you remove clots from the other side, make sure the other sides are all okay, and then finally remove the mop from where the bleeding is likely to be. Have everything, vascular clamps and other things under suture, everything ready, and then remove that final mop and this one. And with spleen, I think in UK we should use vicryl meshes, which is not available here. You can actually use vicryl mesh to wrap the spleen, and that will hold the spleen also. If you want to do splenography or partial splenectomy and things like that. So that is another trick.
Yeah. All right.
And I think the role of, I think you stressed everything very well. If you have the institutional support, if you have ICU, blood bank facility, you probably have a higher threshold of managing, patients conservatively rather than, going in. And the contrary is true. If there is not much of backup and ICU and blood bank, then you have a, lower threshold to opening the patient.
Correct. Yeah. Okay. So the liver is another, common organ that's involved and very similar to the spleen. You have the AAST grading for liver also. All right. And WSES, the World Society of Emergency Surgeons, they have a similar thing, and they group it into mild, moderate, and severe grades of injury. Okay. And even in liver, in fact, in all organs, solid organs, conservative treatment must be the treatment of choice. Always the case in grade 1 and 2. You don't have to worry about it at all. And in select grade 3 and grade 4 patients, because failure rates in this are twice as much as in the lower grades. For example, if it's 6 or 7% failure rate in grade 1 and 2, it will be 15% in grade 3 and 4 injuries. So have that in mind, but that shouldn't stop you from undertaking conservative treatment. But understand that even after the patient has survived the initial injury through your conservative ministrations, you can have a bile leak, you can have abscess, you can have repeat hemorrhage, you may have hemophilia, blood bleeding into the biliary tree, you may be left with a bit of devitalized liver. And this rare phenomenon, I have not seen any of these, but I only read about it, is it can be called a manifestation of an intrahepatic compartment syndrome. Okay, there is such a big hematoma that the liver it's not ruptured, so it's really compressed, and that compression can give you portal hypertension and Budd-Chiari syndrome. Okay, pressure backflow towards the portal system gives you PHT, and towards the hepatic system and the IVC gives you a Budd-Chiari syndrome. So these things can happen, and so all this has to be managed or diagnosed in the post-treatment phase. Okay, hemodynamically stable but bleeding patients. Okay, there is one other option that you have as a bridging gap, and that is to have a temporary aortic balloon. Okay, and it's not that you can put an aortic balloon for 6 hours. It buys you time perhaps for an hour or so before you can get everything ready to get into the OT. So it's said often, but not used. I've used it only once in my life, and obviously it does not address the problem of a bile leak. So it's only for bleeding, and the two very temporary as a bridging. That's the word used for bridging, for temporary measure, and take the patient into the OT for definitive treatment. Your focus is on controlling bleeding. It's only bleeding in spleen. It is bleeding and bile leak in liver and debridement. You can have large chunks of liver that may be dead with injury and lack of blood supply. So that is important. You can't leave large chunks of dead liver behind. Okay. In minor to moderate bleeding, we'll get away with packing with hemostatic foam. You can do a same ligation and suture with a large needle with chromic catgut. You can use cautery, preferably bipolar. Just like you stuff things with gel foam, you can also use an omentum, which is a good hemostatic agent as well as a mechanical medium to put pressure in. All right. And even though liver is a big organ, you can put a lot of mops around it and really block it off. You can leave it like that. If you can't deal with it for 48 hours, nothing happens. And you have to go back in and correct it. And if you can't do it in your institution, you can even transfer the patient with the packs in situ to be dealt with in a specialist center. And as I mentioned earlier, generous incision, 2 to 3 large suction tubes, manual compression is very important. Just put mops around it when there's a lot of bleeding, manually compress it. And if you can't get your fingers around it, quickly mobilize the liver. It's very easy to mobilize the liver to such an extent that it is only hanging by the hepatic veins holding it onto the IVC. Just have to cut the, the ligamentum teres, falciform ligament, cut the left triangular ligament and the right triangular ligament. Everything will be open, and then the liver will be hanging forward. It's very easy, when we imagine, when you have not seen it and done it, it sounds very dramatic, but it isn't. I've done it and it's very, very easy to do that. So when you do that, mobilize the liver and put a lot of maps around it and mops around it and just compress it with your two hands on either side, and then let the anesthetist catch up with the patient. He is hypotensive. Remember, he is very ill. So let him give 4 or 5 units of blood and get the BP up, and then you start the definitive process if you can. Otherwise, pack them up and then come back 48 hours later. That option is always there. Remember that the only time you do not open the ligaments if you see a big hematoma there. A big hematoma, particularly in the right and left triangular ligaments, essentially means that there is a damage to the hepatic veins, okay, where it is avulsed off the IVC perhaps. When that happens, the intact ligament, those are the peritoneal folds, will be tamponading the bleed. It's a venous bleed, low pressure bleed. But if you cut into the ligaments and then open up, then you take away the tamponade effect and the patient will bleed. So remember, do not open the triangular ligaments if there is a hematoma there. The other option you have, of course, is a very easy thing. Pringle maneuver. Put a soft clamp across the bile duct, the hepatic artery, and the portal vein in the lesser free edge of the lesser omentum. A lot of debate, if you look at the literature, people talk about not having it for more than 30 minutes, never having it for more than 20 minutes, but 30 to 60 minutes is safe. There are reports of people having used it for 75 minutes without any problem whatsoever. Remember, the decision to pack or suture or stuff with omentum or gel foam or whatever must be made quickly. And that depends, of course, on experience. If you're new, then you can't make a very informed judgment about it, but it doesn't matter. If you're new and you have no help, just pack. Don't attempt anything more, because sometimes those attempts of doing something other than packing can actually worsen the bleeding. And please note that packing can damage vessels deep inside the track of the knife or the bullet or whatever. And so big vessels, hepatic branches of the portal veins, hepatic veins or whatever, tributaries, may be opened up, and so your packing may not work. But as I said, just like in the spleen, direct suture can also work. Now, if there is a laceration which is so unstable and you find that there are little pieces of bleeding liver hanging out of the main bulk of the liver, just like you do in a formal hepatectomy, you do a finger fracture. The only difference here is that you don't bother with an anatomical resection. It's been known that in trauma, if you attempt an anatomical resection, you end up with more trouble, more morbidity and more bleeding. Okay, so the hepatic resection that you do is non-anatomic in this situation. Sometimes you can actually, ligate the hepatic artery completely. It supplies 25% of the circulation, 75% is in the portal vein. So even if you cut off the hepatic arterial supply, the liver will not die. Okay, so this is as far as the main hepatic parenchyma is concerned. In the real challenge, and in my life I've done it once, the repair of a hepatic veins damage. As I said, mobilize the liver. Mobilize the liver with the triangular ligaments. I was lucky enough to see a 1 centimeter hole where the hepatic vein joined the IVC. It was a young lady with a road traffic accident, and it was quite a dramatic situation. But we managed to suture it and stop the bleeding, and the patient survived to tell the tale. If you have difficulty with the bleeding where you cannot suture it directly, you can do a veno-venous bypass. Okay, so that isolate that segment of the IVC where the hepatic vein joins it, so that there's no bleeding. You can see the rupture and there is no bleeding, and you can repair it under vision. Okay, these are all dramatic things not done in the average operation theater, but done very well in specialist trauma centers. And that's something we have to bear in mind. This is a classic situation of packing with the liver. Obviously, after you do it, it will be a laparostomy. Do not close the abdomen. Come back 48 hours later to gently take out the pack and see how the bleeding is or whatever. This is another, I've taken it from the internet. It's not my case. Another method where if you have a huge through and through gap like this, you can use a plastic bag, okay, described by actually an Egyptian surgeon. Pack it up with mops. Obviously, plastic bags with holes in it, because it has absorbed the blood. And pack it up with mops and then shove it right through and through. Gives you a very good tamponade. Okay, and this is again a bridging method. Don't take it that this is the definitive treatment. Because after you take it out in 48 hours, you'll end up further bleeding and further big bile leaks, which you will have to try and stop whatever happens. Okay, so these are the techniques that can be used. And complications, remember, in addition to the common hemorrhage and intra-abdominal abscess and infection, you can have liver failure. If a large part of the liver is involved, you can have a bilioma or a biliary fistula. And of course, anything to do with kidney failure, kidney bleeding, and kidney disease, you can have a hepatorenal syndrome, and so you end up with a kidney failure and sepsis. Sepsis is common to everything. So as far as liver is concerned, always remember that apart from the bleeding, bile leak is your issue, is a problem for you. It can be either a bilioma or a biliary fistula, and liver failure can occur. Those are the things that you must bear in mind. Any questions?
No, sir.
Okay. All right. Vinod, unmuted. So you have anything to ask, Vinod? Nothing?
No, sir. No, sir.
Okay. All right. Pancreas and duodenum are not common, less than 2 to 4% of all abdominal injuries. But when they do occur, they're a big challenge to surgeons, even experienced surgeons. Remember that the very large force is involved. By the time an anterior force damages the pancreas, it will have damaged several other organs on its way. Associated injuries are very common. So it is good policy to get amylase and lipase in all abdominal trauma cases. If it is high, it's not prognostic, but it will get your antenna up that you must give attention to the pancreas. Okay. And immediately it may not be possible. So it's a good idea to repeat it maybe 12 hours later. And even the CECT, it's good to, not just for pancreas, even for the liver, it's good to repeat it maybe 12 or 24 hours later, just to see what is happening in that intervening period. Okay. And of course, if you have some free air or bowel content seen, surgery is an absolute requirement. We talk about angiography and ERCP in pancreatic injuries, but that happens much later. Okay. Angiography sometimes may be employed early if there is any bleeding from that area. But ERCP is not something that you do on the day or the subsequent day. It happens much later, 3-4 days later. But if you have gone in, okay, without much idea of what's happening, without imaging, then it's always mandatory to open the lesser sac, that's the gastropolycomentum, and look at the pancreas retroperitoneum in the area of the pancreas, and cockerize the duodenum if it's not obviously, badly damaged. If it's damaged also, you need to cockerize to deal with it. But to look at the possible injury to the extrahepatic biliary area, it's good to cockerize the duodenum and have a look. Just like all other organs, you have a duodenum injury scale. I put it up to show you that it is there. You can look it up. I can share this with you. You can look it up later. And similarly, a pancreatic injury scale. All it shows, particularly the pancreas, is whether the duct is damaged or not. Your damage to the surrounding areas, the inflammation, the sepsis rate, mortality, these are all worse if there is a ductal damage and a ductal leak. And so you will find that the duct comes into play beyond grade 3. Before that, there is no ductal injury. In grade 3, it's small because it is distal. Okay. The distal damage is less. Grade 4 and 5, it's high because it will be either mid or proximal pancreatic duct that is damaged. So this is classically the way you see. You can see the extravasation. D is extravasation of the dye there, and this is the head of the area, the head of the pancreas, which looks hazy and edematous. A bit of a damage there, and there is free air retroperitoneum here with the solid arrow there, solid straight arrow, which means corroborates the fact that the duodenum is damaged. So this is the kind of information that you get typically. This is, you can see the classic transection of the pancreas across the middle here, the hematoma and collections around it. So classic transection, the mid body, because the compression against the spine, the pancreas just splits. In an occasional patient with earlier grade, lower grade injuries, you can have a non-operative management. Can be considered again for higher grades if stable. And as I kept on saying, repeat scans are very important. Endoscopic intervention in duct injury also occurs a few days after the injury. It doesn't happen immediately. Now, what happens if you have a big hematoma, either in the wall of the duodenum or around the duodenum? Then you can have a duodenal obstruction. Patient cannot eat. And you cannot not do anything beyond 2 weeks. If the patient is stable, non-septic, if either of these things happen, if it's unstable or septic, you go in earlier. But if you're waiting and the duodenum doesn't open up, it's recommended that you don't wait beyond 2 weeks. Just go in and do something about it. What you do, I'll tell you later. But in the meantime, as we keep on saying, beyond 5 days, you need to have some kind of nutritional support, TPN, or a feeding jejunostomy can be considered. Okay, slightly two, even though these two go in hand in hand, you need to discuss the damage control for the duodenum and the pancreas separately, even though you probably do both of them together. Damage control is a very important thing. Very rarely you will find a kind of laceration which you can repair directly. Honestly, I think it's very rare. I've never done it. If it's a larger area and you're also worried about the vascularity of the edges of a little damage, you can put a jejunoduodenostomy. And for everything, with or without a repair of the duodenum, you can consider pyloric exclusion. All right, well, you can staple across just proximal to the pylorus, the stomach, and then do a GJ for feeding the patient. If you find that along with the duodenal damage, there is probably biliary damage as well, extrahepatic biliary tree, CBD, for example, you will probably have to do a biliary diversion as well. If the head of the pancreas and stomach are both, and duodenum are both shattered, then you do a Whipple's. Please remember that's not at the first time operation. Okay, you just drain the area well, do a damage control, stabilize the patient, and do this 48, 72 hours later. Okay, and for pancreas, you can do a simple drainage. If there's just a hematoma with or without a minor pancreatic leak, just a simple drainage. You may want to put a sump drain rather than an ordinary drain. An alternative is to put a couple of drains, one for irrigation and one for drainage. If it is the distal end, grade 3, that is involved, you can easily do a distal pancreatectomy. If the spleen is not involved, always think about preserving the spleen. If it's a proximal damage, do a Whipple's. And if there is no need for resection, without the destruction of the parenchyma, if you have a problem with a pseudocyst because of ductal damage, then you can do an internal drainage. Similarly, for a fistula, if you have a fistula perhaps from the the mid body of the pancreas, for example, you can do a distal pancreatectomy, take away that part, and put a loop of jejunum onto the cut free end of the pancreas that is remaining in situ. So some kind of drainage can be considered for a fistula also. But as I said, keep on saying, these are not done in the first instance. It's only damage control. These are all done later, a few days after the initial episode. Again, complications, duodenal stricture, duodenal fistula, pseudocyst, pancreatic fistula, and an abscess. These are all, they stand to reason. And you cannot deduce these things. You can work it out and, face it in your clinical challenges or when you write an exam. My last bit is the kidney. Questions, comments, and doubts on pancreas.
Sir, this pylori exclusion with the GJ, is it
Yeah.
for duodenum or even for the pancreas also, sir?
Only for
Something like
duodenum.
ampullary.
No, only for duodenum. If the duodenum is okay and only the pancreas is damaged, you don't have to do all this.
Okay.
It's for the duodenum. Yeah. Okay, moving on to the kidney now. Now, again, there is I put this up to show you that it exists. You will get it on the net, so you don't have to worry about mugging this up. The principles are the same. Is the capsule intact? If there's a laceration, how deep is the laceration? How much of the hilar structures, the blood supply, is involved? These are the three things that are used for giving all these classifications. This is a pictorial representation, just a subcapsular hematoma. You can see it's a laceration, but it is not involving the medulla. It's only in the cortex. Here it involves the medulla also. Here it involves the pelvis of the kidney. Here pelvis and blood vessels, everything is involved. Okay, that's the kind of damage, the shattered kidney. That's the kind of damage that you can get. And these are the typical pictures that you see. You can see that this is a grade 2 injury. Okay. Hematoma with a little laceration, but not involving the medulla. Here it's grade 4. It's injured, and you can see the parenchyma is damaged, and all the way down to the pelvis, you have this laceration. Okay, it's a multidisciplinary approach. Kidney damage is not as dangerous or life-threatening as other damages, liver or spleen, and because, of course, they can also bleed a lot, but because it's retroperitoneal, it gets tamponaded by the retroperitoneum. NOM is a treatment of choice. There are some people who go against it. They say the higher degrees of damage to the kidney always explore, because they claim that the post-operative morbidity after you explore a grade 3 or grade 4 kidney injury is less than the post-conservative treatment course. But that is not completely proven. The controversy exists. But I think by and large, the consensus is that you don't explore the kidney for damage soon. Okay. Angioembolization should be selective. That's a very important thing. There must be a selective catheterization of the branches of the renal artery, not the main renal artery. Same balloon occlusion. I mention it because I just want you to know that there's an option not often done. You also have recourse to two other things in the kidney that you don't have for other organs. One of them is cystourethropy and stenting, which you can do from below. And you can do a percutaneous drainage of collections. It can be hematoma, it can be blood collection, it can be pus, it can be urinoma. So even if the parenchyma is damaged and there's a collection there, you have a percutaneous drainage option in the kidney. And those are more often used, a ureteric stent and a percutaneous drainage. They're more often used than exploration in the case of the kidney. Now, the problem comes when the patient is very unwell. It occurs in all organs. You do not have the wherewithal or the opportunity to do a CT to know what the grade of the injury is. You are blindly exploring the patient. And that actually is a fairly common scenario in many, many large trauma centers. So if the kidney, when the other surgeons are doing something else, maybe dealing with the spleen or the liver or a bowel or something, you have a few minutes. If you want to know more about the kidney, there is an option for getting an intraoperative IVP. That's one thing that you can exercise. And when you do explore the kidney for its damage, again, a controversy there. Should you just cut into the Glisson's capsule or the perirenal tissue and then look at the trauma and the lacerations, or should you first get control first? Okay. And should it be a formal control, isolating the arteries, or you can just put a soft clamp across the renal hilum and see what happens? All right. But whatever happens, it's important to mobilize the kidney. Get into the pararetinal tissues, go behind it so that you mobilize it so that you can hold the kidney in your hand, compress it between the fingers on the back and the thumb in the front. That is the kind of mobilization you need to have. The consensus is generally to loop the renal vessels first. More often than not, people would prefer to uh, dissect just to the right of or to the, it depends on which side the kidney is. Look at the hilum right to the just next to the aorta and mobilize the artery and put a loop around it so that you can clamp it. You can tighten the loop if and when required. Or the other thing is, if you do not want to repair, you can pack it. It's much easier to pack the kidney, wrap it up in mops, as it were, just like you do for the spleen or the liver. Much easier for the kidney. Do it and then come back 48 hours later or 72 hours later. These are the options for the kidney. Now, whatever happens, okay, in wherever you are, particularly in a retroperitoneal organ like the kidney, after you evacuate the hematoma, get enough drainage. Good large bore drains with or without suction. I always prefer suction drainage. You may end up with partial nephrectomy or a total nephrectomy, which means that when you are going in without investigations and you're dealing with a damage to one side, whatever you do, it's a good idea to look at just by palpation, look at the other kidney, the opposite kidney, and confirm that that is okay. So that with peace, you can do partial or total nephrectomy on the affected side. So it's good to look at the opposite side and operatively confirm that it looks okay. This is when you do not have recourse to a pre-op CD. Okay, pelvis can be damaged, not just the parenchyma. So there you have an option of not only ureteric stent but also a percutaneous nephrostomy. And in very rare cases, I've never had to do it, I've not seen it being done, but the book says that you can actually undertake a repair of the pelvis as well. And if you have an avulsion of the renal artery, people have repaired it, but the success rate is low, only 25%. 1 in 4 of those things used salvage. Okay, that brings me to the end of the discussion on the kidney. Happy to answer, take questions, take comments. Students first, questions. No questions. Comments. No comments. So a standard statement of all teachers. When it is like this, either you know everything or either this was a great class or it was a completely useless class. So for my own mental comfort, I'll consider it a great class and go to sleep happily. All right. Okay, registrars, comments, questions.
Sir, it was
So
a
no,
very comprehensive class, sir. Like
Okay.
what exactly needs to be done in every scenarios, it was very well dealt, sir.
All right. But next time you have a situation like this, please call Ravi.
Yes, sir. Yes.
Don't try these things for yourselves. Yeah. Okay. Sanya.
so no questions. It was a very good class, sir.
All
Like
right.
she said, in proper, it was very crisp and nice in what situation, what has to be done. It's very good class.
Unfortunately, we don't see too many trauma cases here. Okay.
Yes.
But fortunately, when I was training, I had a lot of exposure for blunt trauma. If you work in the United States, you have a lot of exposure for penetrating trauma as well, a lot of bullet injuries and all that. We haven't done many bullet injuries. We have seen some knife injuries.
Yeah.
Most of them were road traffic accident, blunt trauma. But there's quite a lot of it. If you're in a busy unit, you'll face quite a lot of it, and we gained a lot of experience, which was nice. Yeah, Ravi, your final comments before we
very
close.
practical guide to management of the trauma, organ wise, and I think complications that of managing conservatively and surgically, all things were well delineated. I think what students have to remember is the liver trauma that you see from the anterior surface when you open the abdomen is much more easily handled than what appears behind. If the patient has a decelerating injury, as sir said, and there is sudden, severe hypotension, majority of the time you won't be able to salvage if the liver is avulsed off the inferior vena cava. I think majority of them you can't salvage them. But I think if there is bleeding that appears from behind, I think packing and pack that and then waiting for 48 hours and get more help and more blood and patient is more stable. If you can handle it in your center, do it. Otherwise, send it to a specialized center. I think that is the message that sir I think mentioned very well. I think that is what you guys have to remember. I think otherwise liver is much more amenable for packing and conservative treatment as opposed to other organs. I think it was a very comprehensive practical guide to management of organ specific trauma. Thank you, sir.
Okay, thank you and good night, everybody.